Good morning and welcome to CCR&R's webinar, Health and Safety Checklist for IQ4K. The mute button has been turned on for all attendees. You should be able to hear us, but we will not be able to hear you. If you do have questions during this interactive webinar, you can post them in the question box. If you have any technical issues, please give me a call at 712-786-3493, and I'll help you once the webinar is started. For your reference, certificates will be issued through your regional training specialist within the next week. Please contact them if you do not receive one. For groups who are listening, please send your attendee list to your regional training specialist. Additionally, handouts are available for this training. You can find the handouts on the tab on the navigation toolbar. This webinar session will be recorded for future use. We would now like to start the webinar. Please help me welcome Healthy Child Care Iowa Coordinator for the Iowa Department of Public Health, Child Care Nurse Consultant, Heidi Hotvet.
Thanks, Bobby, and welcome. This is Heidi Hotvet, and I appreciate everyone taking their time out of today for a couple hours to just allow me to share some information about the health and safety checklist and where that fits into the new Iowa quality rating system, Iowa Quality for Kids. So as we know, the Iowa Quality for Kids will be our new Iowa quality rating system. We don't have a timeline yet for when that release will happen. However, we have been preparing to, as well as you have all been preparing, to roll this out as soon as we get the okay from DHS, that we can start using the tools available to us for this new system. So IQ4K, Building Quality Environments One Block at a Time, is really a big shift towards a continuous quality improvement approach. In our current system, we have a system that's based on a point system where programs can, and as you know, receive high points in some areas and very minimal points in other areas. And we, as the oversight, the QRS oversight team, as well as I know all of you as CCR&R consultants and training specialists, have sometimes had frustrations with our current system because of this point system. Programs who have high points in, say, the health and safety section, but maybe don't have as high points in others, or as I know it's been challenging sometimes for our nurse consultant group, is that we'll get the phone call from the child care provider and they really just want 1 point in the health and safety area. And so we'll go out and spend quite a bit of time working with them on one of our tools. Usually it's the first tool we like to use in the current system is the injury prevention checklist. And we will assess their environment and have possibly sometimes a lot of recommendations for improvement for quality purposes in their injury prevention checklist, and then want to follow up with the child care provider to ensure those quality improvements are made. And because they only are requesting 1 point for the visit, then there's no follow-up. So we don't have that continuous quality improvement approach in our current system because of that. And so it's exciting that we're going to be moving to a CQI approach where programs are really looking at coming in with a level 1 and moving or working towards improving in quality as they apply at the higher levels of the QRS system. There's definitely in the new system an increased emphasis on evidence-based practices. And that was something that I know has been an important part that as a team and as a state, we've really wanted to look at those evidence-based tools and practices to support the programs that are applying for the quality rating or for the IQ4K. There's going to be a change in categories And I'm going to explain a little bit about the categories that that are going to be impacting our nurse consultant group. But for additional information about all the categories as a whole with IQ4K, the center application and, well, not application, I guess the center guidance document and the homes document with the categories and the expectations for IQ4K are listed on the DHS website under the quality rating system, the current system. So they do have some templates or drafts, I guess I would call them, of what the categories are going to look like. So if you want some additional information on that, please visit the DHS website. So nurse consultants will be playing an important role in the Iowa Quality for Kids. And I don't know if some of you know me, but I've been working as the coordinator for Healthy Childcare Iowa and the nurse consultant lead for the Iowa Department of Public Health for the last 3 years, and actually helped on the TA team for about 5 years or 6 years now. My previous experience as the nurse consultant was as a local nurse consultant in Clinton and Jackson counties. So I've worked as a nurse consultant since 2007 and have really a lot of experience working with the quality rating system that we currently have. And it's been exciting to be able to be a part of the IQ4K and working on the oversight team to look at improvements we can make with the new system. One recommendation that was brought to the oversight committee was that we really felt that the nurse consultants could play an important role in the new system. And that was a little bit challenging for our state. Many of you know that we have in the past had nurse consultant services in some areas and then limited or no nurse consultant services in other areas of the state. When I originally started as the coordinator and 3 years ago, we had 24 counties throughout the state without nurse consultant services, which was a huge challenge for us. As we've been working towards improving our nurse consultant services so that they're statewide, we've had a lot of successes. And just recently, starting the beginning of this year, we had a few vacant counties still to go. And as of last week, I just found out that starting July 1, we will have all 99 counties covered with nurse consultant services, which is a super exciting time for us as a team to make sure that we have local nurse consultants in all areas. So that's a huge shout out and excitement. And I hope that that's exciting for you to have that partnership with the nurse consultant, because we know working in a teamwork approach with providers, encouraging them to improve quality and to apply for their quality rating system currently and in the new system, I think having the access to the nurse consultant is huge. And we always have had recently in the last few years, we have had a TA approach where we had some state-funded TA and the coordinator as myself working in the role so that we could help cover counties that didn't have a local nurse consultant. But this will be a huge shift for us coming in July, that we will have all 99 counties with local nurse consultant services. So that's exciting. So because we've been working very hard and really partnering to try to expand our nurse consultants statewide, that has been a big challenge and and to be honest with you, it was a concern brought up many times about how can we require nurse consultant services for the new IQ4K when we didn't have statewide coverage. And I had assured DHS that that was a goal that we had, and IDPH had a commitment to that. And my bureau chief has been great about that partnership. And so we're excited that we've moved that and been able to succeed in that area. So for the new IQ4K, the nurse consultant services will be required in 2 areas. And the first area is going to be the professional development category. And so that's not optional, it's required. and that is in the medication administration skills competency training and skills test out requirement. So that's for all home providers as well as center director staff who administer medication. And that comes in at IQ4K level 2 in the new system. That's the same skills competency that we've been doing as an optional activity in the environment section in our current quality rating system. So that's not going to really change. Medication skills competency training has went from a 5-hour course to a 2-hour course, which has made it much more convenient for providers to be able to take that competency training. And then the skills test out requirement is in the new system will be the same as what is in currently, as a test out initially, and then every 2 years they would be testing out. So the course is good for 5 years, and the test out requirement is every 2 years. That has worked really well. We have been working hard to already encourage providers to take the medication administration skills competency, and we've been having training statewide in many areas of the state every quarter by the local nurse consultants for home and centers to be able to take that. The requirement for center director and staff who administer medication, that question actually came up at our recent oversight meeting with a question of, well, do we track who's administering medications? And I don't know that we'll have a tracking requirement or system of who is actually working and do they all have their medication skills competency training and test out requirement completed. It's going to be at a quality level that they would be listing who have taken that course, and they would be providing that documentation that they've had the course and the test out. I've had questions that have been brought to me via phone calls, emails, and an oversight about that medication administration. And just so you understand, that is a course that is a requirement. Medication administration, no matter where a person would be, maybe in, say, if you were in the hospital setting, a medication would be provided through a nurse, an RN, who is taking coursework related to medication administration. But you might also be having medication given to you in, say, a hospital setting, clinic setting, a group home setting, nursing home setting, that a person would have taken medication administration, a course, and have a skills competency requirement at like a medication aid level, which that's a 16-hour course. It's a licensed course by the state of Iowa, and that's consistent nationally. In the school setting, there is also a medication administration skills competency course and test out requirement for anyone who administers medication. And some of you might be familiar with that, but if the school nurse isn't there to administer a medication to a child in the school setting, then that person is trained through a skills competency course. That's actually through the AEA. I've reviewed that course and have been working with the Department of Education to have that approved through DHS for IQ4K. And then this test out requirement would be done by the school nurse with the person who's been trained to administer the medication. This is also a requirement in Head Start centers in terms of medication administration. So this is really moving into a quality level for providers at a level 2, that any child, whether they be in the school setting or they were in a hospital setting or they were in a child care based setting, that there would be a competent person administering their medication so that they would prevent medication errors for that child. And that's really exciting. That's going to be a requirement. The environment category is a requirement for the nurse consultant to provide the on-site assessment using the health and safety checklist for early care and education programs. And that's what we're going to focus on today, so that you can understand where that checklist, what that looks like, and how that will work in the new system. And that comes in at IQ4K level 3 to 5 for all homes and centers. There's a couple additional areas in the IQ4K that child care nurse consultants may help to support providers in quality. And those two categories are the nutrition and physical activity category and the teaching and learning category. The nutritional and physical activity category is where providers will complete a self-assessment and develop a quality action plan for both nutrition and physical activity. And many of you work already with NAPSAC or the Healthy Kids, Healthy Futures resources. And nurse consultants have also been working using those two resources currently. And actually, I did back even as far back as 2007 with, or 2009, I think, for NAPSAC. So it's been around a while. It's a great resource now. NAPSAC is online. It's very convenient for providers. I know that CCR&R is the lead for working with NAPSAC with providers, which is great. But just so you are aware that nurse consultants have been working with providers on a couple projects related to nutrition and physical activity. So there might be providers that have already worked with a nurse consultant in this area and may want to continue with those plans that they had already worked on. That might lead them into the application with the IQ4K. But we'll kind of work through that as time goes on. I know that the nurse consultant group just finished a project related to NAPSAC, and that's coming to an end. So I'm not sure how involved they will be in this category, but just so that you know that they may be helpful to support providers in that area and be helpful for CCR&R consultants working with providers to say, oh yeah, I worked with my nurse consultant in that area. And you could say, well, you might want to connect with your local nurse consultant again so that you can make sure you have that tool in place. The other area is the teaching and learning category. And this is the category that promotes developmental screening and inclusive environments. And as you know, nurse consultants have been working with care planning for children with special health needs to make sure that there's inclusive environments. So nurse consultants definitely will support providers in this area and can help with that care planning when needed. There are also nurse consultants have been trained in in the developmental screening tool, the ASQ3 and SE. And so some of our nurse consultants, actually, that's a project within their own agencies where they provide developmental screening resources and on-site consultation for childcare providers in this area. So that's something that you could definitely reach out to your local nurse consultant and say, I have a provider that's really wanting to work on some developmental screening or inclusive environments, and could you be helpful to assist them in those areas? So those are some great opportunities for partnering and to work together as a team to really support that provider to improve quality. We're going to get into the health and safety checklist for early care and education programs, and I'm going to give you some background information on this tool. And this actually is one of your handouts. So here's a little bit of background. This is actually a tool, a nationally recognized tool. It was developed by the California Child Care Health Program, which is part of the UC San Francisco School of Nursing and Department of Family Health Care Nursing. And this is California Child Care Health Program is very similar to kind of our Healthy Childcare Iowa program. So a lot of resources, and I'll actually pull up the website so you can see that. But this tool was developed and released back in 2014. So it's been 5 years since it's been out. And it is a research-based tool. So initially when this project was worked on, we've been working with Abby Alcon, who is the director of the California Child Care Health Program. And she said that she had looked at this research, looking at what are some key health and safety items that are part of the Caring for Our Children recommendations that are observable and have the ability for an outside observer to assess for a level of quality related to a program. And they looked at initially I think it was 138 items that were part of the Caring for Our Children stepping stones, that were those high quality, really high risk for injury for children, those standards in caring for our children, and looked at developing a tool for assessing those. So they worked on that tool and had their initial research study released based on those items, those 100. They actually looked at 138 and they narrowed it down to 112. Part of the reason they went down to 112 items was because they really looked at what item numbers for the standards with caring for our children that were very observable and could be rated on a Likert scale, so that there was no bias. That was kind of an interesting, really trying to look at being consistent with whoever the observer was, so that there was consistency across. And that research, like I said, was released, and it was interesting. That research study really shared some great information about the tool and how it was used. They actually looked at programs that were, I'd say, higher quality programs. Head Start programs is where they looked at some Head Start programs and some programs that were already participating in their own national or their own states quality rating system, some NACE programs. And they utilized the tool and looked at what the scoring was with those programs and what those programs demonstrated in terms of quality with their scoring. And they also compared the tool to say they didn't want to duplicate tools that were already available. And one tool that they wanted to do a crosswalk with and to look at was the environmental rating scale, either the Eckers or the Itters. Looking at, we don't want to be duplicative, but we wanted to look at, they wanted to have a research-based tool that was looking at different things than what environmental rating scale was looking at. So that was really great that they were able to work on this tool and support it with research and have a research study released related to the tool. Then in January 2019, because of Caring for Our Children 4th edition coming out, then the tool was updated with some language changes as well as links. So the tool is available online. You guys have a copy of it. It was part of the handouts, but the tool is available online. And I'm just gonna end my show real quick, and I just want to pull up the website for the California. So here's the tool. And then this is the California Child Care Health Program. So if you've never been on this site, I would highly recommend that you go on, because there's a lot of resources on this site, kind of similar to the Healthy Child Care Iowa site with some handouts and some tools. But this is, I'll just click on the resource. So they have some publications, and those are free. They can be downloaded and printed. So there's a lot of different fact sheets, and there's some information and some posters and some training. So if there's anything, this might be a great site for you to look at and use some of those resources. But if you'd like to know more about the this checklist and you want to go into a little bit more information, you can go under projects, and it's listed under the project tab. So I'm going to go ahead and return to our slide here. So like I said, we have, we have been working with Abby. She's been really excellent with guiding our use of this document, of this tool. We've been in training with this tool and then giving us support with questions. We're actually going to be the 5th state for nurse consultants to use the tool. And Arizona currently has nurse consultants that are using the tool as part of their QRS system. It's like a pre-application optional tool that they're using with programs. Some of the other states, California, of course, Arizona, North Carolina. Gosh, now I have to think of what other states. I know there's 2 others, so I'll can't think of them off the top of my head. Sorry about that. But we will be, like I said, the fifth state for using the tool. So that's exciting. And it's going to replace, hopefully, eventually, the injury prevention checklist and the health and safety assessment. So that's the goal, is once we move to the new system that will be replacing. As I said, it's based on Caring for Our Children Standards, 4th edition. The 138 Caring for Our Children Stepping Stones, I said that earlier. And then there was 72 standards they, determined to be observable. So something that an outside observer could observe and could score. And that's how they came up with the 112 items that are part of the health and safety checklist. And then many of the items in the checklist include observable components of a standard. So there might be a standard in Caring for Our Children, and we're just looking at the observable part of that standard, not the whole standard. Like I said, the items are assessed on a Likert scale of a 1 to 4. So 1 is going to be equal to never, it never occurs, and 4 is always. There are options for NA and no opportunity, which is really huge for us as nurse consultants using this tool, because currently in our tool, especially in our injury prevention checklist, it's very challenging because we're assessing all items and we really don't have the opportunity to do no opportunity because, like say in the outdoor area, I did an observational injury prevention checklist this winter at a site. And, there was so much snow on the ground, there was no way I could do any kind of scoring or evaluation of the outdoor environment. And so in our current injury prevention checklist, I just needed to put in that tool unable to assess due to snow, with a goal that I would be able to come back out and assess that environment once the snow was gone, hopefully in the spring. And that is not the best way for assessing a tool, in my opinion, is to not be able to assess the items that you need to assess. So for the health and safety checklist that California developed, there is an NA, which if it does not apply to the classroom or program, that item is not assessed and it is not counted towards their total score, which is great. So if they don't care for infants, those items are not assessed and those are skipped, and they're not going to impact the final score that the program receives. The no opportunity is also the same way, as if there is no opportunity to observe that item, say like the outdoor environment because of snow, we would observe the indoor environment and look at those items, but those items that are marked as no opportunity, it does not count towards their overall score. So observable in the checklist is defined as it requires interaction with the staff or director only to ask where to find an item or identify products. So, for example, we may ask for permission to open first aid kits or to open cabinets, or we'll ask, where is your medication stored? Or we might ask, where do you have your fire extinguishers in the building? Or where do you have your carbon monoxide detectors in the building, either in the home or the center? And so we can ask those things, but we're really just observing what's available. So once they tell us, well, we have the carbon monoxide located here, then we can go and actually see where that is located. Observable is we have the time when we're walking through the program, and that's what's really great about this tool. It takes a 2 to 3 hour period of time total. So that's a very different tool than what we're currently using with the injury prevention checklist and the health and safety assessment that we currently use. Is we might spend a whole day observing a program with our current tools, and that can be very time consuming for the staff as well as the nurse consultant. It can be very intrusive in a program's environment for an observer to be there all day. So we're just looking at a period of time, an observable period of time between 2 and 3 hours, and we're scoring them during that period. The standard item is seen and evaluated in an objective way. We've been in training to understand the standard and the item, and then to really be objective in our way that is scored. Observation also may include opening windows, taking measurements. Definitely for the outdoor environment, we do a lot of measurements, reading labels, looking at medication, expiration dates, things like that. So it's definitely something you would see and then you would score it. Observable does not require checking records or documents such as the child immunizations or looking at program policies. So it's very different than like our current child record review assessment. So we're really just looking at what we are observing while we're on site. A little bit about the health and safety checklist tool and some training. So we started training on this checklist back in May, the nurse consultants as a group in May 2018. So we've been a year in training, and then we had a follow-up training day in September. We've been having monthly practice scenarios that after that May initial date, then we had monthly practice scenarios that were sent out, and we did a kind of a survey monkey where we would do a scenario. What would you have some key things in the scenario so they could figure out how they would score it, and then they would do the survey monkey and score it, so we could get a group scoring going so people could kind of see what the results were of that, and then follow up with correct answers, and then the rationale was sent out. The nurse consultants have been practicing using the checklist for the past year, so that's been a little challenging because programs know we can't be using the tool for any kind of points in our current system because this tool is only available in the IQ4K. But we've been working with programs that are the higher quality programs that we already know and work with. So we've reached out to most of our nurse consultants have worked with level 3, 4s, or 5s to practice using the checklist. And so it's been a great opportunity for programs to see what the checklist is all about, to kind of understand it in the new system, and then to be working with those high quality programs that are used to having observers coming in, so that hasn't been too intrusive. Once we've been practicing, we've been doing some checklist questions and reviews. We've had regional meetings that we've been doing as a group where there's a Q&A part about specific item numbers, and then getting some additional guidance and feedback from California when we've had questions that have come up. We just started this spring inter-rater reliability. So we're doing inter-rater reliability, which is great to have that opportunity to use a tool that we can do inter-rater reliability, because we haven't had a really good system for that in our current tools. So the health and safety checklist has guidelines for inter-rater reliability, and we've been performing those. The CCNC TA mentoring team, which would be Amy Caritas, Kristen Schlen, Deb Geimer, Kim Gonzalez, and myself, and we've all been able to meet our reliability scoring. And so now we're going out to local nurse consultants to complete our reliability scoring. And so far, so good. It's been going great. I've done a few myself. I know that other TA mentoring team members have been out working with their local nurse consultants for reliability. So I'm going to go into the checklist. And like I said, you have that was a handout. So if you wanted to specifically look at it, because I'm providing some information on it. So the checklist has 5 main sections: facilities, supervision, sanitation, pools, spas, hot tubs, infants and toddlers. And then in each of those sections, there are specific subscales or item numbers. So for instance, in facilities, there's item numbers that are related to emergencies, medications, equipment and furnishings, both indoors and outdoors. So those are the largest number of items that we score, and that's item numbers 14 through 35 is those equipment and furnishing. And then there's an outdoor section only, which are item numbers 36 through 41. And then there's the section on supervision, and that's really interesting, looking at some things that we haven't looked in our current tools that we use, but really looking at that some of that interaction with and related to physical activity in terms of like teacher-led physical activity. Some item numbers are related to that. Supervision, just as a when they're in the indoor environment, what is their ratio, what is their group size, supervision in the outdoor environment, supervision around water. Nutrition, eating and drinking, that's another thing that's another section that we have not had as part of our tools, really looking at that nutrition piece. So that's great to have that as part of this tool. The next subscales related to sanitation, and these are this is a big one. We're looking at personal hygiene in both children and the staff. So that's very interesting, looking at kind of that from a vantage point of both sides of things. And also toothbrushing. So there's just 2 questions related to toothbrushing, and that's 2 items that we score. And like I said, if the program does not provide toothbrushing, then that is a no opportunity for us to be able to put that, or I'm sorry, an NA if they don't provide it, or if we're not there during the toothbrushing time slot, then that might be a no opportunity that they actually provide toothbrushing, but we weren't able to observe it. So those are a couple items. And then there is a food safety, food handling, environmental health, and those are item numbers 75 through 85. So there's 10 items that you're scoring, looking at the food safety and prep and looking at that, but also observing the environment related to the preparation of the food in the kitchen area, how it's stored. So that's been a different approach too. We also have not had that as our current tool. So that's been great to have that opportunity to have this tool include those items. Section 4 is pools, spas, and hot tubs. And so there's really just a couple questions in this area, a couple items that you're observing for. And with most of our programs, those are NAs. If it's center-based and they do not have any pools, spas, or hot tubs on site, then those are NAs. For homes, we will probably have more opportunity to assess these 2 items, especially related to if they have a hot tub or if they have a pool on site.
Heidi, we have a question.
Yes, great.
If a child care nurse consultant is going through their observation time and they do see an emergency or danger area, will they stop the observation and address it, or will they finish scoring out and then come back later and say, okay, well, I noticed your pool didn't have the right fencing? Or
they will continue. It depends. I mean, this is if it's an immediate risk, they would need to address it immediately if there was a chance that a child would be immediately injured. Usually what you would do is you would go ahead and assess to finish your observation, and then after that period of time that you're in, and then you would follow up with the director to address those and to share all the items. Actually, they get immediate feedback from this tool. But if there's something that needs to be addressed immediately, that usually is done. We've had a couple where we had a toxic substance that was within reach of a child that we needed to address immediately in the classroom, or a choking hazard. We've had that happen. I'm trying to think of some other things that have come up where there was immediate, we needed to intervene, or we had a child that was climbing on a step. That actually happened to me the other day, and the staff did not see the child in that situation, and so we had to stop and say something to the staff to assist with that child's needs. So does that help?
yes, thank you, Heidi.
Great question. And that's interesting because I know that that's a little bit different than how ERS, or I know that that's been a question or a challenge that has been brought up with environmental rating scale in terms of the observer not having any interaction, or and this tool is not quite as the same. We don't want to be intrusive in the program for sure, but when it comes to a safety issue, then we will address it if needed. So great question. Infants and toddlers is the next section, and the subscales are related to a personal relationship. There's a couple questions in that area. Diapering, that's a big one. There's a lot of injury prevention, and then there's some infant only in that section, which if a program doesn't care for infants, and they're a school-based program, and that would not apply. So that would be the infant toddler section would not be completed. And so those are question item numbers 89 all the way through 112. If it's a program where they do serve infants and toddlers, but we happen to be there on an observational day, say with a home where they do not have any infants in care that day, maybe they have a part-time infant that comes in, we are observing, so we do not score items that we're not observing for that day. So that's a little change for us as nurse consultants, and that's been some training that we've had to really review in terms of this as an observational tool. And so some of that is related to planning. California has really recommended, when you set up your visit, find out what the program serves, and then do the best to observe during a time frame where you'll be able to observe the most number of items, which would be great. So we try to plan our day so that we can observe. If it's a school-based program and we're there to observe school-based children, last week I actually did a school-based program with a nurse consultant for inter-rater reliability, and we went at 3:30 or 3:15 when the school got out, and the kids went into the school-based program and in their after-school program, and we observed them until we were there till about 6:00 p.m. So that is really looking and using this tool that's the best to observe the items that we need to observe for that program to be able to score it. So as I said, that research and we're going to be the 5th state using this tool, but research in their original research study, they found that they could quickly go through the tool within a 2 to 3 hour period to be able to observe all the items that they need that the nurse would need to observe. That's really great for planning, so we know that, and we can say that up front with the program, so they know that we're going to be there a maximum of 3 hours, which is helpful for their scheduling. The items are organized in order to facilitate making the observations as you walk through the facility, and rating them as you go. We actually have iPads that we have the tool downloaded on, so we can use our iPad and we can walk through and we can rate as we go, which is really helpful. There are some item numbers where the nurse consultant may need to ask the director or the staff member a question, and those are identified by an asterisk. But as I said previously, we really try to be not interacting with the staff and being intrusive into their environment. We're really just trying to do that observation while we're there. We will, like I said, need to open cabinets, read some labels, do all those kinds of things. This is a little change. We're just looking at one classroom. So it's chosen at random to observe, and we observe that classroom indoors and outdoors. So when we get there, the program will not necessarily be aware or know of, with a home, they'll know we'll be observing the full group of kids, because if they're all in a mixed group, then we would be looking at the overall environment and rating it. But in a center, the classroom will be chosen at random when we get there, and we'll observe those children both indoors and outdoors as they go through their day in that 2 to 3 hour period. So like I said, planning is really important, but when we get to the on-site visit, coming in and asking the director, we'd like to be able to observe children in both indoor and outdoor environment. So do you have a classroom that would be soon going outdoors that we could observe? So that's kind of a way that we can, it's random, but we can gear that around so that we'll have the best group that we'll observe for that day. And then there's 3 items that relate to the full program and not just one classroom. So then we rate those 3. Do we have another question?
Yes, I see that you require a non-absorbent paper liner to be used. We didn't think this was required by ITERs. How does this play out regarding the scoring?
So the way the scoring is for the diaper changing, or actually for all of them, there are in some of these item numbers, there's a group of items that are best practice according to Caring for Our Children, which we have, we've always used Caring for Our Children as our kind of our base. So for instance, we know there's going to be some programs that don't always have all of those items, all of those parts of the item assessed in their environment. So for instance, with diaper changing, they might not use a paper liner. So it will affect the scoring, as in a 1 to 4. If you think of a Likert scale, 1 would be they never follow any of the item, and 4 would be they always do. So for that program that doesn't use a paper liner, then they would not be able to have a 4, because that would mean that they were meeting the full standard in that item number. However, if they follow everything else with the diaper change in terms of using gloves and wiping front to back and making sure that the child's that they remove the diaper and wipe the child's hands and their own hands using a wipe, and following all those other best practice standards, they would be able to have a 3 out of that Likert score of 1 to 4. Does that help? Any other questions?
Thank you, Heidi.
Sure. Okay. Just explaining a little bit of the scale, the rating scale, and then we're actually going to go work through a couple scenarios. So let me just explain a little bit about the rating scale before we get into that. So like I said, a 1 will be never. So that is that none of the components of the item were met. So and we're gonna have programs that have a never. I will tell you that the challenge we will have for the state of Iowa is related to our maximum group size and our ratio of child to staff. Because in the environment that we have in the state of Iowa with our, we have such a need for childcare, and we have childcare deserts, and we have challenges in a lot of areas of the state for even finding childcare. Childcare providers follow our licensing requirements for maximum group size and ratio, and they do not follow best practice in many programs. So we already know that as nurse consultants using this tool, that we're going to run into a challenge in that category for group ratio, group size and ratio. So that's a challenge, but that's one score of a 1 is not going to be a problem for a challenge for a program. If they score 4s and 3s and higher ratings in other areas, 1-on-1 item is not going to throw that out in terms of them not having a high score, which is a great part of this tool, because we know there's going to be areas where they're just not going to be able to get high scores and everything. Sometimes that's less than 50% or less than and equal to the amount of components in the items are met. So that would be a 2. 3 is usually, so say for instance, we're doing, I'll refer back to that diaper changing question again. Say, like I said, they follow the diapering procedure using best practice for all of the areas that we're looking at for those components, except they don't use a paper liner when they put the child down. So they are meeting greater than 50% of the components, but not 100%. So then they would score a 3. on that item number. And then 4 is always every component in that item is met, so it's 100%. And then, like I said, I already explained the NA and the no opportunity. So, and we'll go through a couple practice scenarios, and then I'll show you scoring so you can kind of understand how that scoring works. But so there's going to be areas where we're going to have an NA, which then that item number is not scored. It's not given a 1 through 4 rating. It's just not scored, and we don't include it in the total score, as well as no opportunity. I'm going to pause just really quick. We've had a couple questions, but I think we're doing great on time, and just wanted to check with you real quick. I'll pause. Does anybody have any questions so far? Well, I don't see that we're getting any questions. Bobby, any questions?
No, Heidi, I don't see anything coming through at this time.
Okay, great. We're going to continue on then. And if you do have a question that comes up, just please just put a little chat in there so we can address it. So we're going to go to our practice scenarios. So if you want to pull out that handout, and we're going to go to item number 64. So that would be on page in the health and safety checklist, that's page 8. So this is a subscale. This is in sanitation in that category. And the subscale is personal hygiene, hand washing. And so the item number, so we would be observing on site, and the item number is adults and children only use alcohol-based hand sanitizers as an alternative to hand washing with soap and water if hands are not visibly soiled. Hand sanitizers are only used by children over 24 months with adult supervision. And then that item number in the health and safety checklist, if a provider was looking at this, they could click right on and go right to that standard. So the case study, so while the nurse consultant is going through her observational visit, she's noted during the assessment that children in the toddler room were given hand sanitizer during circle time. And the age of the toddlers in the room are 22 to 24 months, because she was told that by the director before she went in to observe that room. So, you know what I should have done, could they do a quick survey? Bobby, could they do that real quick?
Where would they go? Like, have a link for it, or
with the polls?
Yeah, they have to be preset in advance. I don't have any set in there.
That's fine. I just was thinking, gosh, I should have done that with these. But you guys can think about, okay, how would you score that if you were the nurse consultant scoring that? So we're going to think about a 1 for that item 64. If you're looking at page 8, you can look at, there's options of 1, 2, 3, 4, an NA or no opportunity. So we know that we're NA or no opportunity. We're not going to mark either of those, because we do note during the assessment that they're given hand sanitizer during circle time. So we know that that's impacting that. So then we're going to go at scale on a 1, 2, 3, or 4, depending on the item number. So here is the answer. So, actually, no, we're going to we'll look at this. So let me go. Okay. So, one's going to be alcohol-based hand sanitizers are used by adults and children as an alternative to hand washing with soap and water when hands are visibly soiled. Hand sanitizers are used for children under 24 months. So they would get a score of a 1 if that met all of those components in that item number. 2 would be less than or equal to 50%. So say with that, you would be looking at the components. So we're looking at that adult and children over 24 months are only using hand sanitizers as an alternative if hands are not visibly soiled. and there needs to be supervision in there. So we would be kind of assessing, okay, does it fit into there? Because we know that the children are under 24 months, so it's not meeting those components. And then 3 would be that greater than the 50% of the components were met. So say the children were all over 24 months and we saw that they were using that in circle time. How would we score it? Possibly as a 3. Hard to say, because we would need to see were they using that as an alternative, because either they didn't have soap and water available or their hands weren't visibly soiled. So that would be something that we would be observing and deciding. And then 4, alcohol-based hand sanitizers are used by adults and children as an alternative to hand washing if the hands are not visibly soiled, and it's only for children over 24 months and they're using supervision. So that would be the rating of a 4 on that item. So as you can imagine, we would have scored that as a 1. And the reason for that is with the rationale, there's really 2 key points. The children were indoors in a classroom and there was soap and water available for hand washing. Okay, so that would be a key point right there. And it's a group of toddlers, and we really couldn't see if all of their hands were visibly soiled. I mean, we didn't go and intrude into their circle time to see that, but we do know that best practice would be for them to wash their hands with soap and waters, because they're actually there in the classroom and could use the hand washing station to wash their hands. And then we also, the other really big key point is that we know that the children ranged in age from 22 to 24 months. So they were not of the age to be able to use the hand sanitizer. So that right off the bat kind of gave us a key that they would be getting a 1 on this scenario because of that. So any questions on that first scenario? Okay, let's go on to the next one. So now our next practice scenario is item 79. So if you want to turn in your checklist, in your health and safety checklist, to page 10, item 79 is there.
Heidi, while they're turning the pages, we did have a question come in regarding the hand washing. What if there wasn't a sink in the room?
If they didn't have that as an opportunity.
Right.
So we would still go back to, were they under the age of, are they over 24 months or under 24 months? So that would still be a key point. That would be a question to the observer is, okay, they're not able to wash their hands in the classroom. Why are they using the hand sanitizer and passing around during circle time? Best practice would be if they're moving to so that's why the observational part comes in, because if they're moving to mealtime, they should be washing their hands correctly with soap and water. We would definitely need to know the age group before we went into the classroom to make sure that we could score that appropriately. So that would still be rated as a 1.
Okay, thank you, Heidi.
Sure. Okay, well, if we don't have any other questions on that one, let's go to the next one. So item 79, hard, non-porous surfaces soiled with potentially infectious body fluid. For example, toilets, diaper changing tables, blood spills are disinfected. And the EPA registered disinfectant is used according to label instructions. So that's the item number, and it's Caring for Our Children Standard 3301. In the case study, so you're noted during the assessment that the staff used a sanitizing product with a 5-minute dwell time on the diaper changing table after they did their diaper change. So now the nurse consultant will be looking at the item number and say, okay, what do I have for the components? And then how would I score that? So a 1 is none of the hard non-porous surface contaminated with potentially infectious body fluids are disinfected using an EPA registered disinfectant. 2 would be that less than or equal to the surfaces are disinfected using the EPA registered disinfectant. 3 would be that greater than 50% of the surfaces were used with that disinfectant. And then 4 would be that all hard non-porous surfaces contaminated with body fluids are always disinfected using an EPA registered disinfectant. Or no opportunity would be available on this item number, and that would be that we just were not able to observe disinfecting during our 2 to 3 hour visit. So for our scenario, we know that the product that they used, so we only were able to observe one time during our observational period that they were doing one diaper changing. And during that diaper change, they used a sanitizing product and not a disinfectant. So we know that we would have to score that as a 1, because the only time we ever saw the potentially infectious body fluid non-porous surface that needed to be disinfectant, they used a sanitizing product instead of a disinfectant. So we would have to score that as a 1. Now this one's a little bit interesting, because if you were in, say, a classroom setting and that was one diaper change and the program, maybe it was a float staff and she didn't look at the product that she picked up. And so one of the diaper changing times she used a sanitizer, but the rest of the time during the 2 to 3 hour observation, we saw the EPA registered disinfectant, we saw it being used, observed it by other staff. And so it was just this one time that a float staff or maybe somebody mistakenly picked up the wrong product. So then we would score that completely different, as you can imagine, because we're looking at the item as a whole. We're not just judging it as that one episode. We're looking at the item as a whole. So let me back up to the previous slide. So if we observed, like I said, all of the staff during diaper change, and then we saw a staff member, actually maybe a child had a bloody nose and they used their disinfectant spray after they cleaned up that area on the floor, or maybe it was in the outdoor environment, and they used their EPA registered disinfectant all of those times, but the only time was when that staff person mistakenly grabbed the EPA registered sanitizer instead. Then they would, as you can see by our scoring, it would be a 3, because greater than 50% of the time the correct product of disinfectant that is EPA registered was used. Do we have any questions on that one?
Heidi, we do have a question.
Yeah, great.
What is the score if the diaper changing table is observed during the time period, yet the toileting areas are not observed being disinfected?
That's a great question. We would be looking at what areas that they're using, because even at say all they did, we didn't observe the toileting area. We did not observe a blood spill during our observational visit, but we did observe, one or more diaper changing. We would rate it according to what we observed that day.
Okay, thank you, Heidi.
Thanks. So as you kind of can tell from when we first started training on this tool, it was really interesting, because when you read through the questions, you think, oh, well, this is just really kind of easy. You just go through and score it, But there's a lot of really background thinking and training that we've been doing about each of the item numbers, because there's multiple components, and there's scenarios that happen, in one situation could be so different than the next situation. You could be observing an after school program and they do things differently with their program, and then you observe, the next site that you observe is a home-based program. But the great thing about this tool is, because of the way it was developed and researched, it's really clear when you're looking at during that observational window is to be able to score it. And what we found to be really helpful and what was recommended is really look at the item number and look, would it be a 1 or a 4? It's pretty easy to rule out, is it a 1 or is it a 4? They're either always doing it or never doing it. And that's kind of, so you right off the bat can kind of, during your observation, determine that. And then when it gets to the 2 and 3, we're really looking at what is the component and what is it asking for that item for observation, and then what did we see? And there's a notes section for each items. And like I said, when we're doing this on our tablets, it's really great. And we can actually do it without a tablet too. It's something that we can just handwritten, but it's great to have the tablet because you can type in notes as you're going so that you can refer back to as to why did I rate that as a 2 versus a 3, or why did I rate that as a 1 versus a 3? Because in your notes section, you can have some additional information related to those components of that item number. So let's do one, I think we have time for one more practice scenario, and then I want to get into some scoring and then answer additional questions. So this one is practice scenario number 3. So, and to be honest with you, these practice scenarios are all actual scenarios that have happened since I've been using, and other nurse consultants have used this tool in practice. So it's been, so these are real scenarios that have happened in Iowa out in the field. So our subscale is under emergencies, and it's item number 3. So if you want to turn to your page in the health and safety checklist on page 2. And our item number 3 says, phone number for the poison center is posted where it can be seen in an emergency. For example, next to the phone. And that's the standard Caring for Our Children 5291 and 5292. So during your assessment, the poison control number is not posted by the phone or anywhere else that you can see when scanning the room. So the observer, the nurse consultant, is in the observation of the room and scans the room and is trying very being consistent with looking around and trying to find where that poison control number is posted. So after scanning the room, the nurse consultant actually has to ask the staff member where it's posted. So we need to know that so we can see that. So they tell you it's written on the front of the first aid kit. The kit is sitting on a shelf and with the words first aid kit, and it's clearly written and visible. And you take the kit down and you notice on the front of the kit, the poison control number is written in black marker on the kit. So for this item number, the phone number of the poison center is posted where it can be seen in an emergency. For example, next to the phone. So how would you score this subscale? So 1 would be the poison control number is not posted where it can be seen in an emergency and is not available on site. Okay, so let's kind of go back to, I'll kind of run it through this way. If this is how the nurse consultant could look at this. So they're going to look at it, is it a 1? Or they're going to look at a 4. The poison center number is posted and can be easily seen in an emergency. So if you were rating this, you know, we know it's not a 4 because it wasn't easily seen to the point where after even scanning the room, the nurse consultant needed to ask about it. So that's not as clear. So then we're kind of looking at, was it posted at all or was it not available on site? And it's not a 1 because it was available on site. It was written on the front of the first aid kit. So then we kind of go into a 2 and a 3. Is it available on site but not posted, or is it posted on site but not easily seen? Okay, so then our answer here is it's a 2. Okay, so the poison control number is available on site because it was, but it was not posted. And then we go to the rationale. Is the definition to post is to display or affix a notice in a public place. So on the outside of the first aid kit, it was not posting. And the reason it's not posting, if you go into further in the rationale, is if you consider that say a child was poisoned at childcare, say that they accidentally, you know, there was maybe a toxic chemical within reach and they sprayed it in their mouth. Would the staff member reach for a first aid kit? And that's a question of, you know, maybe perhaps they might reach for the first aid kit. But most often, if you witness a child being poisoned, what is the first instinct you're going to do is to call poison control. And so when we say it needs to be seen in an emergency, you know, an emergency always is not going to need the first aid kit. And so the telephone number being written on the first aid kit is not really posted in the location where it's readily available and be able to be seen by the staff in the room, or even a float staff that came into that room. So they would get a 2 for that score. Any questions
Heidi,
on
we
that
do
one?
have a question. Yeah. Will providers have access to the checklist in advance of a child care nurse consultant visit so they know what's going to be observed on? Or are consultants or
Yes.
CCR&R consultants allowed to take the handout or checklist in beforehand, or what's the protocol?
We'll follow the same protocol that we've had with our current. So DHS has them posted on their website, their current tools, which is our injury prevention checklist and our health and safety assessment. And so this tool, actually the link is already on the document that's posted on the DHS quality rating tab. So they can actually look at this now. What I foresee is that I would ask that, and I know that DHS already has CCR&R posting the tools available for providers to be able to access off of their website, and we will also have it on our website. So it'll be in multiple locations, so that prior to the visit, you know, we want the director and staff and the home provider to have access to the tool so they know what's going to be observed and what maybe some areas that they know right off the bat that they would maybe want to change. So great question. I think we'll just continue on. I had one more practice scenario, but I think we're going to skip that. Any questions, or we can move on to a little bit more of total scoring I want to share in some of our documents. I'm gonna skip this one, and you guys have it in your handout. So scoring is pretty quick. So the score is determined by the total number of items assessed. So we know we start out with 112 items, and then we take out any NAs or no opportunities for those items that were not included in our observation. So then, so like I have a little math there on my screen, but it's like, so we have 112 items, and say we had 5 subscales that were no opportunity or NAs. So then our total would be 107 items that we actually scored. So then we add up the scores for all of the numbers of those 107 items that we scored. We add them up together. So for example, in this scenario, we add up our total score, and our total score is of those 107 items. So you're adding every 2 and 3 and 4 and 1, all of those scores together, and say, for instance, you got a score of 244. You would divide that by your 107 items, and then you would have a overall score of 2.28. So what does that 2.28? So when you think about it on a Likert scale, a 1, if they had a 1.0 as their overall score, that means that they scored a 1 for an overall score for the items that were assessed, which would be very low. A 4 for an overall score would mean that they met everything, and everything we were going through with the 107 items that they had met that score of always meeting all of those item numbers, which would be a 4. For information from the first release of the research that California did, when they looked at the programs that they assessed, their average score or their mean score was 2.51. So a little bit above average in terms of their total, 2.51. That was their mean score for the programs that they assessed. And they'll be coming out actually with a second research study. They're working on that right now. Abby told me that they're hoping to have that out by this summer. And it's with the tools that Arizona's nurse consultants have been using, so that they're looking at what is their scoring looking like for those programs that are going into Arizona's system for QRS. And so the range from their first research study was that the lowest overall score was a 2.14, and they went as high as 2.76, and then actually they had some hires of 3. So we don't expect that our programs in Iowa are going to score in the real high, 3s or 4s, because we know that we're looking at many items, and some of the items that we have programs that will score in the 1s and 2s. So we're really looking at what is their overall score taken together, and like in this example would be 2.28. So I'm going to move into a little bit about kind of some of the forms that we're going to use and what you'll see. So we will share, the nurse consultant will actually be able to email and give a hard copy of the tool that was scored, and they will have all of those items and the scoring that they received at the day of the observation. So, if it was a item number 3 and they got a score of a 1, or item number 4 and they got a score of a 4, so they'll know what their scores are. And then on that tool, the health and safety checklist tool, they will actually have the link to that standard so they can look it up. They can actually click on. That's why we want to send it as a PDF document, so that the home provider or center director could actually just click right on the link and go right to that standard on caring for our children, rather than having to look it up. So that makes it nice. But there's going to be a signature form that will be part of IQ4K, and that's where, right currently we have signatures that are required, and that's the kind of the documentation or the requirement needed for submitting the application. And so we're going to have a signature form. It's going to look like this. This is actually, we still have it in draft only because the draft was approved by our oversight committee, but it's still marked as draft, and it's only available for nurses right now. Because, and the reason we have it marked as draft, is because we have not released IQ4K yet, and so will not be marked as the official form until that occurs.
Heidi, we do have a question.
Sure.
So the overall score checklist, will that go into the IQ4K website, or just the final score with the signature sheet?
Just the signature form will be uploaded. The nurse consultant will so the provider will have the signature form, and they will have the checklist, the actual checklist. But in terms of what DHS is wanting to see, they just want to see the signature scores form, which will have the overall score on there and the signatures from the nurse consultant and the director, owner director. So they won't have additional paper that they'll be uploading. However, like I said, the staff, the director owner will have a copy of the tool that can be shared with staff. They can look at areas where they scored low for some additional professional development in that area. They can work with their CCR&R consultants in areas maybe they scored low. They can work with their nurse consultant to address those areas where they scored low. So that tool will be helpful for that continuous quality improvement part of it, by able to look at that tool.
Okay, so the CCNCs won't have an actual database of all the scores. It'll just be the one signature total that goes into IQ4K.
Repeat that. You say that again.
So will there be like a database where the CCNCs report their overall scores, or is it only just going through IQ4K?
Well, currently, and we're working towards that, IQ4K will have total score. score. However, there actually has been some discussion, and this is something that's going on in California. They would like to have some kind of data retrieval, and that's why we're really wanting to do these on our tablets and really wanting to download these checklists so that the goal would be possibly an app that we would be entering this information into. But there's a lot of, we don't own this checklist. This is owned by California, so we're waiting on their lead. But there is another checklist or another assessment tool that is being used by North Carolina that they have for, it's actually kind of like our child record review, and they're collecting data, and it's working through an app system where then they can look at consistently as a state, they can look at where do they score low, and they can look at that data. And I'm really hopeful that we can move to that, but we will not be able to have that unless California decides that's the route they want to go. There is a possibility, and I've presented this to IDPH, that we would do some data collection once we're using this tool, where we could fairly easily upload information from these tools so that we could put in a database of the scores. So great question.
Okay, thank you. And then we do have another question. So if you're to put in a descriptive score and it was 2.28, the question is what do you call it? And that
it's called the overall score, yeah, and it'll be actually on the signature form. And let me go through the signature form, and then I'll kind of show you what they need in terms of the for IQ4K, what they need for minimums and minimal level scores for the categories. So if I can just go through, and then we can kind of see if the question was answered. So like I said, they'll have, this will be the signature form. It'll be completed by the nurse consultant and the owner director or site director. And the form's just going to have some program demographics, the nurse consultant's name, the date of the assessment, the overall health and safety score, which will be that 2.8 number or 2.53 or whatever the number is based on their total. And then there's a part where the childcare provider, and this is the CQI, the continuous quality improvement piece. And I'll show you this next form. The signature form is signed only after the nurse consultant has reviewed their action steps. And their action steps form, I'll show you that next, is really what are they doing with this information. So they have this tool and they have their scores, and they can look at each item number that was assessed the day of the observation. And then where do they go from here with that? Because if they're working up the ladder of the levels in the IQ4K system, they're going to have to meet a minimum for a level 4 and a level 5. And so this will allow them to have some plan and action steps, plan of where do they go next with their program to improve their score in the areas where they scored low. So where they scored the 1s and 2s, how can they raise those up? And then there will be a signature and date. The next form, like I said, is those action steps, and this is what it looks like. And it really just is a very simple fillable PDF for the program to fill out. It does not have to go into great details. It's really going to be like they're going to look at their subscales, for instance, emergencies, medications, and if they scored low in those item numbers, then they as a program will determine what items they want to that they're not meeting that national standard, and then what steps are they going to take to move towards that. So for instance, if they're scoring low, say in the outdoor environment, because they need to do some raking of their surfacing, they don't have the proper depth, they've got some broken toys, then they will put in what their plan or what their action steps that they're going to take in order to improve their scoring in that area. And this is something that they can work with their nurse consultant to complete, but the action steps form is really their decision in terms of what they want to work on to improve their overall score. And I do like that because it's an accountability issue. It's really the program in our current tools. I would say that in general, the nurse consultants are writing their plans for them. I mean, to be honest with you, I'm just going to be frank. We tend to, as nurse consultants, develop what action steps need to be taken, and we talk to the programs about that. And that really, for continuous quality improvement, is not a good plan, because we all know, we're as consultants, when you work with programs, is when it's their plan and it's when it's their something that they actively want to work on, they're more engaged, and when they have to put that thought into what they can change and make work in their facility. And so that's what's exciting for me, is that this allows the program to really look at those items where they scored low and really have some conversation as to how they could see moving those scores up. And that's the whole goal, of course, for quality. Like I said, it's a fillable PDF. It really is that continuous quality improvement. And that plan is something that I think will be a great a tool for them to be able to use with quality improvement. And then, like I said, the nurse consultant can provide guidance, but it's really their plan. But it really needs to reflect their priority actions, and that's what I think is important. So here's some requirements. So at a level 3, there is no minimum score required. So that's not much of a change than what we really have right now. We, as the nurse consultants utilize the tool and they have a point system, we don't require, we can have a program that says, I want to have, I need 2 points, and I would like you to do a child record review and an injury prevention assessment. And so the nurse consultant would complete both of those tools in our current system, and those 2 points would be signed off by the nurse consultant, and the provider maybe will make no changes whatsoever to their program and will turn in their application. And then 2 years later, they can request another nurse consultant to work with them, and they might have made a few changes, but maybe not many at all. And I've worked with programs in exactly in these cases where I would go out and do 2 additional tools when they are going to reapply, and they maybe have not made any changes from the 2 years previously. And so then I'm just doing basically the same IPC report that looks very similar to the previous IPC report, and there's been no change that has occurred over time. And so we're not at a level 3. The checklist is going to be completed. They're going to still complete that signature form and need to submit that for IQ4K, and they will need to fill out and work on that continuous quality improvement action steps plan, but there isn't going to be a minimum score required on the overall checklist. Level 4, they will need to score 2.5 or higher. So we went with, since research showed that a mean score of 2.51 nationally, using this tool with the states that were using it, that was a mean score, or their meaning average score of 2.5. And so we felt that Iowa level 4 homes and centers should be at least average, which would be a 2.5 or higher. And then a level 5 is a 2.75 or higher. And that's, like I said, not requiring it to be a 3 or a 4, but we really want to look at that tool as a whole and the items that have been assessed and scored as that their average, their overall score would be a 2.75 or higher. Some additional information. So it's really going to be 2 visits by the nurse consultant, as maybe you've probably already figured that out, is that on-site visit of that 3-hour maximum visit to complete the checklist. And then the second visit will be reviewing that action steps and signature form then would be signed. So they'll review the action steps, they'll have that total score, overall score, of whatever it is, 2.4 or 2.5 or whatever it is, and then the program and the nurse consultant will both sign that off so that it's signed, and then that will be submitted for IQ4K. The signature form is good for 2 years. We've already got that in our guidance document, similar to what we've had for now in our current program. If the program does not meet the minimum score needed for the level 4 or 5, they may request a reassessment. And there's a process for that. So what research has said is that to increase a score, so say a program got a 2.5 and they're a current level 4, but they wanted to apply for a level 5 and they scored a 2.5 overall score. So they did not meet the 2.75. Research has shown from this tool that it takes about 6 months working on their action steps and with a nurse consultant or with another consultant to improve those action steps to increase their score by 9%. Well, 9%, 2.5 to 2.75 is 9%. So it may take a program 6 months to raise that score to that 2.75 requirement for a level 5. However, we are going to allow the program to request the reassessment in 60 to 90 days. So maybe, and the reason that we're doing that is because to expect or to tell a program that they need to wait 6 months to work on those things to increase their score to get that level 5, we felt that would be frustrating for programs. And so we felt we did get this okayed and talked with DHS about this, is that that reassessment request we would do in 60 to 90 days, because if they have 2 months, they can work on some things. Maybe it's some easy stuff that they can fix. They have some action steps and they've got some things that are pretty basic and they can fix them right away to improve their score. And maybe their score was really close. Maybe they need a 2.75 for a level 5 and they got a 2.7, and they're very close. So in 2 months, we could come back out, do a reassessment, observation visit, and rescore them, and hopefully that they have obtained the score that they need. So there is a process for that, and that's a process for either a level 4 or a level 5 for asking that reassessment. We do have in our role guidance, and the role guidance, as our child care nurse consultant role guidance, is available for public. And that's something that's on our Healthy Childcare Iowa website under our consultant tab. So if you want to see, currently in our role guidance, we have all the information in there of what our nurse consultant role is and our tools that we use. And we have our current tools in there with the child record review, injury prevention checklist, and the health and safety assessment. But we also have the new tool in there for IQ4K with the health and safety checklist with the process. So those timelines are included in that, and the forms are included in that. So if you guys want to review that, that's available for you. We do have in our role guidance, and this was something that DHS had asked that I put in the role guidance and wanted an agreement that the nurse consultant would schedule a program request and assessment of the health and safety checklist, that the nurse consultant would schedule that within 10 to 15 working days or 2 to 3 weeks. So that programs are not waiting. And if that's a challenge for anyone, that's something that we actually started last year, talked with all the nurse consultants about that. That's in their role guidance. They know that. That's been a little challenging for programs that have new nurse consultants or nurse consultants in training. But please reach out to me and let me know if we're running into a problem where we have a nurse consultant that's having challenges with scheduling. And that can be scheduling on both sides. I mean, I always like to give everybody the benefit of the doubt, but I know in my own role as a local nurse consultant and also as a regional and as a TA team member, and then now as the coordinator, I still do assessments, and I know that I will schedule something and then I get a call from the director that they need to reschedule. So, I mean, we need to work together to meet that goal of getting in as quickly as possible for programs, but we know that changes do occur in scheduling. So, and sometimes weather. We had a lot of weather issues this year for sure, like all of you know.
Heidi, we do have another couple questions.
Great.
How far in advance of the IQ4K app being submitted can this check place take place?
Well, my understanding through the oversight committee is that we will be notified by DHS when IQ4K will be released, and then we would be able to start using this tool as soon as that notification occurs, because it's good for 2 years.
Okay, so I think I'm reading that a little bit differently. So if somebody's going to put an IQ4K app in May, how far in advance can they do this checklist? Can they do it in July, or do they need to wait till January, or is there a
Once the IQ4K is released and we're good to use this checklist, then since the checklist is good for 2 years, really a program could at any time ask for that checklist to be completed. And it's really, to me, if they're not going to apply till July and they want to have it done 6 months prior, that's great, especially if they're going for those higher scores, because then if they don't get the score that they need, say they don't have the 2.75 for overall score, then that gives them time to work and improve their score, which is great, so that's not required for a program, but it is highly encouraged, I'd say, to plan ahead. And we say that with all of our programs. I know with applying for the quality rating system now, it's always best to plan ahead and do it earlier than I need it by tomorrow because I'm going to apply on Monday, which seems to happen a lot. So we'll just have to work with providers to make sure that they are aware of that. But we really cannot use this tool until IQ4K is released, and that we're just DHS will direct that when that occurs. So.
Okay, thank you, Heidi. The next one is asking, you stated at the beginning that all 99 counties will have CCNC services as of July 1.
Mm-hmm.
What will this look like? Will there be a CCNC that can use this tool or current health and safety tools in all counties as an on-site visit, or is this TA only?
Nope, that will be a local nurse consultant statewide. So we had out of the 99 counties, we had 3 counties that were left, Carroll, Audubon, Guthrie, and they just informed me last week that they will be partnering with another agency, local agency, and they did receive funding to be able to start that July 1. So they were our last counties without local nurse consultant access. We still are going to work through some of those challenges that we have in areas where there's limited funding. However, we have had really good success this year, I'd say since the beginning since January to January this year, where we've had some additional resources that we could put towards local agencies so that they could support the nurse consultant when there was funding issues. And we will continue to break funding between ECI. ECI is definitely our largest funder, but we do have funding sources. I know other nurse consultant agencies have funding through local community partnerships, through United Way, through Child Health, through some other resources. So that's just being evaluated every year to see how we can improve that collaboration. So that should be for on-site visits and for nurse consultant services. So.
Okay, great, thank you. Additionally, let's say a child care nurse consultant comes in on September 1st and uses the tool. Granted, IQ4K is now rolling.
Mm-hmm.
When would the provider expect a report about their scoring? Does it take a week or a month, or what's that look like?
Well, the timeline for them to get immediate feedback is they will actually be able to receive verbally how the visit went with some items, that they can go through the checklist immediately, either showing them a hard form or a hard, if they did it by computer, they'll be able to show on their tablet where their scoring was. In terms of then, so they'll have that. And so that really, it's going to be up to the director with those action steps. So if they need to have those action steps, that document filled out before the signature form can be completed. So the second visit could be as easy as, that next week without any problem if the program is able to complete those action step documents so that can be done. So immediate, really we want that feedback to be as soon as possible, but the timeline is going to be really directed by the program because they'll need to complete that action step form.
Okay, wonderful. Um, Deb Martins just wanted to say thank you. It's been a very informational webinar. She's wondering after today's webinar, how would you like additional questions submitted to you? Is there a plan you would like for that? How would you want questions to go to the directors and then they forward, or do they do
Um,
that locally?
Yeah, I think right now, we're in the process before the release of this. I think it'd be best to have them directed to me, and if the regional R&R directors would like to send those to me, that'd be great. Or if I know I get questions right now from the from the QRS specialists, and so I would say either going through the QRS specialist or the regional director to me, that would be great.
Okay. Additionally, another question, does the signature form need to be done before they can ask to be reassessed?
Yes. Because the signature form is that we've reviewed those action steps, so they have a plan in place of how they're going to address those low scores, and then they'll have that in writing what their overall score was, and with a signature attached to it.
Okay. So I do have an additional question here from Beth, and I've deleted the old questions once I asked them. So I'm not sure what she's referring to, but she says, so they would need to do 2 forms.
There'll be 2 forms, correct? The signature form is basically just a form that they will be completed with the nurse consultant, and that will be the official document to turn into IQ4K that will give their overall score with a signature and date on it. So that's just a demographic kind of an official form for IQ4K. The action steps document will be kind of that working plan that they will have. So the program will need to complete that.
Okay, thank you, Heidi.
I'll finish with the next few slides. I think we're doing great on time. And then if there's any last questions, we can answer those at the end. So actually, we are to that questions. I thought we had one more. Oh, one thing I was actually going to address and I didn't yet was, I've had some questions. What are we doing with our old tools, or our current tools? I guess they're not old yet, but our injury prevention checklist, and I had that on a previous screen, and our health and safety assessment will be going away. We will not be using either of those tools once we move to IQ4K and we have the ability to use our new health and safety checklist. Our child record review, we're really struggling with that. Like I said a little bit ago, I had mentioned that there's a similar tool that North Carolina has been the lead for nurse consultants across the nation. They actually are training. Our Iowa training project for nurse consultants is based on, and they have been collaborative in allowing us to utilize some of their curriculum for nurse consultants, and they have some research that they've done on health consultation and utilizing nurse and health consultants in the early care environment. And so they have been great with allowing different tools to be accessed and used by their by trained consultants. And they do have a similar tool like our child record review that looks at health records. And I would like to see that we can still utilize that tool with providers, but that will not be tied to quality rating at all. It will be just once IQ4K comes out, we will only be doing the health and safety checklist and the medication skills competency kind of as the two tools that are required for nurse consultants to utilize. And the child record review might change and look a little differently, but we would like to have that as an option for providers because we know that's so important for providers, for nurse consultants to help them with their health records. That's a common question we get, and a lot of consultation that we provide is on health things. So that was one thing I know I forgot to say in a previous slide. So any other, we've got about 15 minutes here for any other questions, or I can share. I do have, my contact information here. Any other concerns, thoughts, questions? I'm gonna just real quick, I wanna show you a couple places here. So on the California Child Care Health Program, under projects, you can go to their past project section, and there's some information on some of the projects that they have done, and the health and safety checklist is on here. There are some additional tools on here, so that's something that you might, you might want to look at if you were looking at some previous projects that they've done. They've done a lot of research projects on their site. And then on the Healthy Childcare Iowa site, I'll just bring that up. As I said, under the childcare nurse consultant section, there is the Find a Consultant, which is our consultant map, and that map will be updated soon, because we have, as soon as we have the full list for our nurse consultants, we currently have 2 nurses in nurse consultants in training, and I'll be updating that map probably for sure in June. And then on here is also our current role guidance. So you can always click on that and look at that. And then also, and like I said, our role guidance includes the current tools we use and kind of the process and the forms for those current tools. And then also it includes the IQ4K tools. So that is also listed in there with that process. The nurse consultant, the role guidance will be updated again. Then we always update in July, so that will be posted as soon as that comes up. And then I'm not quite sure where we will put we will probably link in our resources to either the DHS website or CCR&R, and I guess I can talk with our regional directors about that in terms of how we want to link this tool, so that providers looking either on our website or looking on the DHS website or on the CCR&R website would have access under the quality rating tools to be able to look at that tool ahead of time before the nurse consultant visit. As always, we do have a lot of resources and some of our printed products on our website, and those are forms that we I'll click on the printed products here, and my screen is frozen, so I'm not sure why. Well, I was going to try to click on that, but I can't right now. But our printed products section has a lot of helpful tools on there. I'm sure many of you are familiar with that part of our website, and those are we look at those and update those as needed. I wanted to just let you know that we do have under review right now our infant safe sleep policy. So I wanted to just alert you that that is under review. So if the provider was looking for that document, it would be they would not be able to download that at this time, because we're looking at that and really wanting to align our policy with some national resources and make sure that it aligns also with the IQ4K. Any other questions?
Not seeing anything else come through, Heidi, and we really want to thank you so much for taking time to help our staff figure out the health and safety checklist that's coming new, and very, very helpful for all of us. So thank you.
Thank you so much for attending, and I appreciate all of the great questions. If there's additional questions, please feel free to reach out to me or to reach out to your training specialist, your quality rating quality specialist, and then also to your CCR&R regional directors, and they can submit questions that way if there's additional ones. But I'm always available, phone or email, for questions or concerns. So I appreciate your time, and have a great day and have a great week. Thank you.
Thank you.